All right. So mainly, I think that we are going to focus on the first of the papers. It's called a scoping review because it is more current. It is, I believe, it's from the fall of 2021,
Mm-hmm.
and it's got a more 30,000 foot view of what's happening. We've been sitting with this particular pathology for a couple of years now. And it's kind of amazing how the story has sort of really congealed into something that is bite-sized. Right out of the gate with this paper, I think they mentioned almost immediately that almost the entirety of the pathology comes down to macrophage activation syndrome coupled to this endotheliolitis and thrombic complement-dependent cascade. I'm going to try to find the quote of that really quick. But it's a very broad overview paper, and we're going to refer to the other one as necessary in order to illuminate some of the cascades, like the particular signaling events. But there's no way you're going to memorize those in this class, especially since we're not giving an exam over that. And in general, I find that to be a little bit of a misguided strategy for teaching biology, because if you do end up going into research, you're going to have access to all of these pathways that you're working on in particular. All you need to know is the general strategies that cells use to communicate, and sort of a few of the basic floor plans, like we're going to talk about, like the interferon signaling, chemokines, the ways that the cells essentially accomplish their goals without the actual detailed messenger names, because you're not going to remember that anyways. So let's see here. There's some background too. I'm gonna have to jump between the lecture and the paper, I think, as we go through this. So let's see what's our first slide. Oh, cool. Yeah, I wanted to throw this up since we hadn't really actually looked at this thing yet. So I think this is technically the third lecture. This is the fourth class, and we haven't actually seen this dreaded coronavirus yet, but I wanted to show a picture of it because there it is. It's actually quite a beautiful little crystalline thing, and you can see the lovely little spikes on it. This is a scanning electron microscope picture, so they sputter coat the cells. In this case, these are long epithelial cells, which are the surface cells. So remember, right below these surface cells is where a lot of the action takes place. But you can see these epithelial cells have these really exquisite little hairs on them, which are absolutely essential for clearing debris out of the lungs. Ironically enough, they don't appear to be accomplishing that right here, or they're overwhelmed. And so, yeah, I just wanted to include that. I think that...
I mean, you can kind of begin to see how overwhelmed the cells become with what is happening, right? So obviously the virions are much smaller than the cells are, but the sheer number and quantity of them is basically creating this morass that the cells can't get out of. And when you have this amount of foreign substance in any chamber of your body, you're going to elicit active immune responses. And it may be that many of these viruses, or these virions, for example, have already been covered by neutralizing antibody. And so they've gotten to the point where they're no longer really able to do something harmful. And yet they're still present, and their presence alone is enough to continue the immune response. And so, physical clearing of this stuff is what's really difficult, which is why so many people end up on ventilators. And I've often wondered if there aren't sort of more physical ways of clearing the lungs as opposed to just ventilation. Because like if you have kidney stones, what they'll do sometimes is you can break kidney stones apart using ultrasonic vibration. You put somebody in an elliptical bath, and then you sit them at the node of one of the sound nodes inside of the bath, and the kidney stones will break apart, and then they can urinate them out.
I think there's an analog for this in cystic fibrosis, which is like when your lungs kind of fill up with this mucus, or they actually like manually disrupt the patient's...
like multiple times a day, because cystic fibrosis...
just pat it out of them,
Yeah. I mean, to be fair, that the prognosis for cystic fibrosis is, I think, a life expectancy of 35, so it doesn't work that well.
I do think that there's a lot of other stuff in this picture too. I'm not totally like certain of it, but there seems to be a lot of fibrosis, like a lot of fibrous material, and there's this net syndrome with the fibroblasts that we're going to talk about a little bit later, which seems to contribute more to the pathology. I know it looks like the cells are overwhelmed by the virion particles. I think that's just a sampling bias. Like they've found the frame that shows the most viruses, virions, however we say this. So anyways, I think it's only fair. I wish I'd included this in the first lecture, so I just wanted to bring it back.
Sorry, I wanted to point something out before we leave. So down here at the right, you have this really interesting surface morphology on the cilia themselves. And it looks like there's serious chunks being taken out of the cell membrane, almost exposing the sort of the interior of the cytoskeleton within. And it might very well be that it's part of the pathology, because it seems like when you're more surrounded by these viral particles, that's where you're starting to get more of this sort of defect.
And it's hard to also express like how small this is. So those little hairs are just a piece of the cell. The cell is actually this big hulking thing, and the hairs are just the little pieces that stick out of the top.
It's like the equivalent of very dangerous dandruff. Like size-wise, would you agree?
Yeah, it's about that size, exactly, yeah. They're like little tiny fleas. So, yeah, we don't have a way of showing this right now, but let's keep going. Inflammasome. This is a term that came up too with regard to the innate immunity. But let's jump over to the paper real quick.
Hold on one second. We have to switch the share because it's not set up to it. All right.
So let's talk first about the innate immunity. I actually have my annotated version here.
All right, well, right off the bat, so, I mean, we have that there are multiple phases of COVID-19. And you have that there's a phase where you have these ACE2 receptors that are on the ciliated epithelium of the nasopharynx and upper respiratory tract. And then you have all of these other immune cells that are located inside of the lungs. So you have two different types of cells in the lungs. You have the cells that are the gas-permeable cells, and then you have the cells that are basically doing everything. And the type 2 pneumocytes are the ones that are doing all of the functions. They're also the only ones that are really capable of doing all of the necessary immune signaling to activate the cascade. They also have much higher levels of ACE2. And so that's partially one of the problems with lung dysfunction, is the fact that the virus is able to preferentially interact with the cells that are necessary for actually capillary dilation, for airway opening and closing. And so you're attacking not just the epithelial structural cells, you're attacking the behavioral sort of brain, quote unquote, cells that are there. You have high ACE2 receptor expression not just in the lungs, but you also have it in the fat and in the brain. And so next week we're going to do neurological effects of COVID, and ACE2 receptors in the brain are going to come up with that. The fact that you have high levels of ACE2 in adipose tissue might contribute to the fact that you see obesity as being a significant risk factor for severe COVID, because you just have more of the receptor. More of the receptor gives you more opportunity to interact with the virion.
Yeah, adipose is a synonym for fat. So we talked about the TMPR system last time a bit, which is also necessary for activating the uptake of the viral particles. But the first real hint of immunology we get to is the innate immune system here with the pattern recognition receptors. And we talked about this in general last week with our overview of the molecular immune system, the cellular compartments. And one of the first things they mentioned, which I pulled a little video on, was that these pattern recognition receptors set off a cascade which leads to downstream activation of this transcription factor called NF-kappa B. And that eventually leads to cytokine production, which is the transcription, leads to these proteins called cytokines that are thrown out into the blood. And those trigger inflammasomes. So what is an inflammasome? It's actually a really interesting little piece of machinery that's part of the innate immune system. And can we watch that little video on that really quick, actually?
Yes, but we have to switch the share again.
Yep, let's do it. Did you share with sound?
Oh, but hold on.
Can't hear anything. There's no sound being shared.
Should there be sound?
Yes.
Are you sure?
Yes. Actually, not sure. But did you share with sound?
There's no sound here either.
This is one of the chemokines, not chemokines. This is one of the cytokines. Stimulates this change. For instance, IL-1 beta or IL-18. And these little inactive monomers start to aggregate and form this crystalline structure. I can probably put this on like 1.5 or something. Maybe not. All right, there you have it. Which recruits even more little pieces. And this is just by shape, right? These things just electrostatically fit into the right place. It's like...
And they've been transcribed actively because the process of inflammasome assembly has been started.
Right, exactly. So that's what it means for these cytokines to be instigating the inflammasome complex, is the transcription of all these little pieces and activation of them, so that first step was actually an activation step where some sort of signal like a cytokine causes the shape change in a way that allows it to aggregate and form these more complex structures. Okay, so it's making this really weird looking funnel type structure. It's quite beautiful, actually.
And then you have this other protein called caspase-1. And the process of caspase-1 binding to the inflammasome and dimerizing is what then creates an active form of caspase-1. And caspase-1 is then able to cleave inactive cytokine for being released into the intercellular space. And that way it's able to diffuse throughout the body.
And further amplify the process. Oops, we started over.
Oh, no, sorry.
So it makes these wonderful little windows in the cell, which essentially cause it to rupture. And then hopefully all of your other innate immune effectors come along and clean up the mess. So I guess I had misspoken earlier. The idea is not that the IL-1B and IL-18 trigger the inflammasome. There's other cytokines, which are not mentioned in this paper, downstream of the NF-kappa B pathway that trigger the inflammasome, which then activates the IL-1 beta and IL-18, which have downstream effects in terms of recruiting other immune effectors to the battle.
Mm-hmm. And so This is one of the ways in which you can imagine that the cells are basically able to tune their own death throes, where if you have the inflammasome active inside of the cell, the inflammasome is now activating a ticking time bomb, where by the time that it starts to cleave these gasdermins, the cell can't survive a high concentration of these inside the cytoplasm because they're localized to the membrane and they're going to rupture the cell. You can't have enormous holes in the membrane. But if you have a virus that's actively replicating inside of the body, it's capable of preventing the inflammasome from activating these apoptotic cycles. And so this is one of the ways in which we see where the cell is able to continuously extend its inflammatory lifespan. Because if you swell and you break open and you release the alarmins, then the macrophages can come in and they can devour whatever's there, and then you're basically done. But if you're just constantly there and you're just adding more and more cytokines to the mix, then you've lost a vital ability to tune the response and to basically allow it to go out. Oh, did somebody have a question? I heard someone just for a second. He said, so if the virions like to interact with fat because of ACE2 receptors, can this also cause effects of the organs because of visceral fats? That's interesting. I would imagine that the effects are localized to the tissues that have the ACE receptor first. And then afterwards you have this spread of inflammation throughout the body that becomes nonspecific. And so if you start to have specific organ failure, I would think that it would be most likely due to the fact that you have high systemic inflammation, and the high levels of systemic inflammation are what's tearing apart your body's ability to function, rather than it necessarily being the fact that you have this proximity effect between ACE2 receptors in the viscera and then the viscera being closer to vital organs. Because honestly, I think I have this.
You also need more than just the ACE2 receptor. You need to have these TMPRs to activate the induction of it into the cell.
That's true. But looking at this chart here, you can see that there's a pretty significant ACE. So green is tissues that have ACE2 expression. Red is tissues that have a lower level of ACE2 or a lower than baseline level. And so what you can basically see is the fact that there's almost no systems in the body that escape the presence of ACE2. It's a vital molecule. Do we have a profile of the TMPR receptor profile?
Looking for it.
Oh, here it is. And so most of the body's organ systems are susceptible in one way or another to entry by way of this system. Kidneys, hearts, lungs, and so I would say that there's not necessarily a connection between the fat and that. It looks like the distribution of the TMPR SS2 is pretty similar to the distribution of ACE2, which makes sense. So you have it in brain, heart, kidney, lungs, intestines, which means that by the time that you have virus in your body that has left the lungs and has now basically penetrated into the tissues, it might be circulating, it might be hiding out in macrophages. We'll cover that, where sometimes because these viruses are able to prevent the interferon pathway from being activated, it means that they can be sequestered inside of cells where they're happy to replicate. And as those cells travel through the body, because these are surveillance cells, they're just amoebas that crawl through the body. And when that happens, you end up with a situation where a cell that's carrying virus ends up in an organ system that is disconnected from the lungs, but all of a sudden you have the spread of infection through the lymph system or the blood system. We have something here on ground glass syndrome.
Yeah, we'll get to that in a second. Or maybe we'll get to it right now.
All right.
I'm just going through the paper.
So should we go back to the paper?
Yep.
All right.
see here. So let's look at first.
For some reason, it always turns on the volume when we do that.
Let's look at the first figure here.
Mm-hmm.
Okay, so this is kind of illustrating something we've been talking about a lot so far. So the viral replication phase, which might be problematic in something like Epstein-Barr virus, where you have a highly lytic situation, meaning it's exploding cells just by its replication process, doesn't seem to be it seems to be waning as the symptoms are actually appearing. This is obviously problematic because you can be replicating virus quite actively and be pre-symptomatic, so you might get sick a few days later. So the symptomatic phase doesn't appear to start until about the 5th day, whereas the replication is occurring all the way up through the 5th day. So you may be actually having these in your secretions. Ideally, if you're not, projecting that into the environment, it shouldn't be a problem. And then you see, as soon as the symptoms start, again, being an immunological, the symptoms being immunological in nature, fundamentally, the innate immune response begins at the same time. So at the 5th day, you begin feeling bad, in large part because your immune system is starting to do its inflammatory job. And as a result of the immune system doing its inflammatory job, you have viral debris appearing in the body, right? Because it's doing these destructive processes. It's tearing these things apart. And we're going to go through some of the other mechanisms it does that. But in so much as that viral debris is cleared from the body and the symptoms persist, we're getting into the world of long COVID and persistent immune dysregulation and macrophage activation syndrome, T cell dysfunction. In other words, we're getting into a place where the initial response was not shut off properly. There's no longer a viral threat to your body, but your body is still acting as if there is something going on there. And we have all sorts of clinical symptoms that result at each stage of that. This progressive hypoxia, which is the sort of late stage symptom, is kind of interesting because hypoxia is sort of a marker that you're having death of tissue, particularly in your lungs if they're not getting the oxygen concentrations that they need. Then, well, why is that? Well, there must be some blockage. There must be some death of the little arterioles, little endothelial. We'll get into the endotheliolitis soon, but this is actually an infection of those capillaries inside of the lungs. Not an infection, sorry, an inflammation of those, a disruption of it, often as a result of some of these attacks by the body's own processes that we've already gotten into, including the inflammasome. So that's a really nice figure for illustrating the general idea of what's going on here. Again, something like 99% of people will not suffer their bodies will do essentially clear this virus by the 11th day. We'll slowly deal with the viral debris and reset to baseline. There's an interesting stat right at the beginning of the paper. Approximately 20% of patients who are infected are symptomatic, with many of these requiring hospitalization. Approximately 3% of symptomatic patients have a fatal outcome. So that's about 0.006% of the people who are infected. That's a very, very small percentage of people. So we are generally able to recover the body by this point. This dotted line, what is this dotted line? I wonder. Oh, sorry. Severity of illness, I see, of course. So generally, if your body hasn't recovered by the 14th day to 28th day, then you're looking at prolonged immune dysregulation. And, they don't mention this directly, but you can imagine that if your immune system's dysregulated as a result, or even if this COVID is just a contributing factor, you're going to start running into problems with other infections that you might encounter, particularly if you're in the hospital, because hospitals are notoriously dirty places in terms of transmitting. They have their own set of resident pathologies. There's a lot of viruses and germs, bacteria that hang out in the hospital. And so if your immune system is suffering some exhaustion, you will begin to suffer under those unrelated pathologies as well. Or at least you're at risk. You're at a much higher risk of that.
And the mechanism for that kind of is covered in the next section. So if we start to head into the remainder of section 1, which is talking about the sort of the way that the virus behaves, the cell types that are involved in this, what you see here is that the way that the virus replicates and where it replicates is going to have an effect on transmissibility. If you're replicating mostly in the nasal area and in the pharynx area, it's much easier for something to become aspirated than if the damage is down lower in the lungs. But because of the tropism of the ACE2 receptor, the vast majority of replication is happening higher in the upper airways. And the thing that's different between the strains of COVID-19, of SARS-CoV-2, is that you have different rates of viral replication. And so Delta was thought to have been particularly harmful because of the fact that it replicates in very, very high concentrations inside of the nasopharynx. And so this is what's accounting for its increased transmissibility and virulence. And as you have infected cells, they are releasing these chemokines, they're releasing these cytokines. Everybody is coming to the infected cells, and then you start to have this severe immune response. And this is what I was talking about here. Aspiration of the viral inoculum from the oropharynx into the lung likely occurs in those patients with a high viral load, infecting type 2 pneumocytes and alveolar macrophages. So what's happening is that basically you don't have a direct line between your nose and your deep lung tissue. But the minute that you actually aspirate that stuff into the lungs, you carry it deep into the tissues, where all of a sudden the virus starts to have access to the cells that it can dysregulate to a fatal effect. And so it seems crazy that that would even be on the table, right? Blow your nose instead of sucking it in. Like your parents told you that, but...
I mean, I think part of the reason for the poor signaling with regard to the public health on this issue is that initially it wasn't entirely clear whether the virus was capable of surviving on surfaces. You know, I remember at the beginning of the pandemic, people were spraying down. You go to the grocery store and they're spraying everything down with these chemicals.
My mom and dad sprayed all their newspapers.
Some places they're still doing this, but the virus does not live on surfaces at all. And so this may be a result of this misconception that sort of persists. It's really hard to put these things back in the box once you've got people thinking, all right, this is one way that we can slow it down.
Mm-hmm. And one of the ways in which the infection travels is through these macrophages, like I said. So in the pulmonary phase of COVID-19, macrophages may serve as a Trojan horse, which means that the virus is getting into the macrophages, is able to continuously survive inside of these encapsulations and then be carried to other parts of the body where it's released and causes serious damage. This is actually strangely similar to tuberculosis, where if you've ever talked to anyone who studies tuberculosis or works in public health, it turns out that there's an enormous number of latent tuberculosis infections in the population because you can walk around with a granuloma of tuberculosis inside your lung macrophages for years, if not decades. And what happens is that when the bacterium gets inside of the macrophage, it's able to poke holes in this I'm losing the word. What's the word for the thing that digests things? It's not lysis.
Inflammasome.
No, the cellular compartment.
That pokes holes?
No, the
the thing that digests them.
Yeah.
The lysosome.
The lysosome. There you go. So the lysosome is basically the place where the bacteria are supposed to get into, and they get digested because the pH is increased through proton pumps, and then you can excrete the digested molecules no problem. But tuberculosis has these things, it's called a type 7 secretion system, and it basically is just this spike that comes out and it punctures holes inside the lysosome membrane. And so, yeah, you have all of these proton pumps that are happily pumping away, trying to increase the acidity, but the protons are just leaking away. And so they can reproduce happily inside of these capsules. And at some point, the immune system breaks, or, for example, the macrophage dies because it's activated the inflammasome, and the inflammasome is going, and it produces the holes inside of the membrane, macrophage bursts, and instead of releasing a bunch of trash, it's actually releasing all of these sequestered either virions or tuberculosis bacteria that are then able to establish infection in a new part of the body. And these macrophages are really, really pro-inflammatory, which means that they're secreting all of these cytokines that are very, very strongly activating the immune system, causing excessive lung inflammation to begin to occur. We first see that the platelets are interacting with the monocyte, and so you have these like platelet monocyte aggregates. And the minute that you start to have platelets that are part of this, you start to get into the problem that you're going to start creating clumpy, terrible clots and chunks of stuff in places that really need a thin layer of mucus with a single cell for gas permeability. And the same thing can be said for if you have in the blood the accumulation of pro-inflammatory macrophages with massive quantities of platelets that are attached to them. You're basically asking for a thrombotic cascade. Would you agree?
Yeah, it's worsened even further by just basic innate complement cascading. I put a video on that too, which might be worth watching. I'm not sure if you want to save the thrombic stuff for later or do it right now.
We can save it. There's another section on thrombosis.
Sure.
So
go ahead. One thing I wanted to also add is that a lot of these, when you were talking about the lysozymes, it made me think of back to we were talking about these pattern recognition receptors, which we generally think of on the surface of cells, but it turns out that they're also internally located, so that when some of the part of the viral construction process inside of your cell is part of the assembly, is the right word, is that they're actually assembled in these little vesicles. And there's actually pattern recognition receptors inside of those vesicles too that can tell that something, like they'll see a piece of viral DNA inside of the body to begin with. And I can go back to this later. We have, I think, a slide for this. So it's not always that they're just scanning the external environment. It seems like your body is naturally scanning for patterns inside of the vesicles, inside of its own cells as well. Yeah, you can pull up a little figure for this too.
I think I had them at the very end. This is foolish.
Quick preview.
Yeah, quick preview of everything to look forward to. Aha. Here, so we basically have these toll-like receptors, which are the pattern recognition receptors that are normally on the outside of the body. Then you have, as you would expect, so if you have something on the outside of the body and you're able to create this endosome through endocytosis of the membrane, you would then also have them on the inside of the vesicle. But then you also have these NOD proteins, NOD1 and NOD2, which have basically the same structure as the toll-like receptors, but instead of being on the outside of the cells, and they interact their assembly is slightly different. The different surfaces touch each other, but they're of the same family in terms of greater superstructure. They're actually inside of the body, and what happens is that when you have these lysosomes and the bacteria or viruses are degraded, some of the chemicals from that are able to leak into the cytoplasm. And these proteins, these NOD complexes, are able to actually sense the fact that there's a chemical present that is the signature of either a virus or of a bacteria. And then it starts this entire phosphorylation cascade, which leads to NF-kappa B being activated. NF-kappa B is the transcription factor that then activates the cytokine production and interferon production and everything else that basically is necessary for the body to be ready to deal with a virus.
I had another picture of it too, but the thing is loading real slow.
So moving on with the paper, let's see. While you look, do you want to look for it right now?
Maybe it's not. Maybe that's sufficient.
All right.
It's too slow. Too slow.
So, oh my goodness. Okay. So, as we saw in Figure 1, basically you have, this is a time course of 28 days, right? And you can see that if you're still not doing well after 2 weeks, it is probably because you are entering into this phase of there being some pretty serious body level issues that are the result of the immune system no longer being able to respond to the threat. And what we start to see in figure 2 here, which we're going to be talking about for this next section, is that there is a phase of PCR where you are likely positive, but you are no longer infectious. The infectious window here is roughly at the end of week, basically before you really start to show severe symptoms. Do you want to go over to something else?
I just want to make sure we didn't skip over the macrophage activation syndrome, because somebody mentioned that beforehand. I feel like it's gonna get away from us. Is it?
I think that the macrophage activation syndrome is actually in this coming section.
Okay, cool.
So basically what you have is that you have this incubation period where you have replication, and this is the only time that you are going to be highly infectious because you have vast quantities of the virus around, but it is not the only time that you are going to be PCR positive. So what they're showing is that, I mean, they're not showing, they're referencing somebody else, but they're saying that you can be PCR positive for up to 70 days, despite the fact that you can no longer culture virus from the person 14 days after the first day of symptoms. So you have this pretty wild dynamic where the clearance of the virus from the body, even after it's no longer, I would say, functional or replicable, takes a really, really, really long time. And
there's going to be DNA available, right? Because what is the PCR looking? Sorry, not DNA, RNA. So what is the PCR test looking for? Well, it's looking for those little pieces of RNA that are inside of the virions. Mm-hmm. So even if you have a bunch of exploded virions, you might have... DNA is actually... Sorry, RNA. I keep saying DNA. Nucleic acid, RNA, is a really gummy substance. I'm not sure if you have all had the chance to play with isolation of DNA from some organism before, but it has this consistency almost like jelly or something. Mm. So it's not surprising to me that it would find ways to linger around... in the body, in the nooks and crannies. I don't know how to answer that. Somebody had a question. Go ahead.
Is this graph, do you think it'd be the same for different variants of COVID, or less pathogenic variants? I guess Omicron, would it be a little bit different, do you think?
I'm not sure for sure, but I would expect it to be very similar. I think the difference in the pathogenicity does not have to do with how long those DNA fragments are hanging out in the body. I think that it probably has more to do with the type of cells that it's interested in colonizing. And I think that really comes down to, from what I've seen about Omicron, it's mostly colonizing the upper airway as opposed to the lower airway. It's not as susceptible to this aspiration syndrome that Dr. Benbury was talking about earlier.
It might also be that some of the mutations are preventing it from interfering with regular antiviral programs, and so it might be that Omicron's immune evasion isn't quite as strong as, isn't quite as strong as other strains. And so basically what's happening is that you're seeing a relatively similar passage, but what's the clearance from the body. Actually, I'm going to go out on a limb, and I would say that for Omicron, I would expect that the PCR likely positive would be shorter. Because I think that you would be getting a less severe immune reaction, and if you're getting a less severe immune reaction, you would consequently have to have less stuff in the body. And you would have to be better at clearing it.
I would say it would be longer because the virions are more localized to the upper respiratory area where the test swab is occurring at. So your sampling background is going to go up. You have more people in the stadium to ask for their color of shirt or whatever you're doing.
I love your analogies. I didn't totally follow, though. Can you tell me again?
Yeah, so if in the case of, say, Delta or something that's actually, you're expressing the virions mostly down in the chest or something, you're less likely to detect them in the nose. by PCR.
Do you
which is really
express delta more in the chest?
That's my. I mean, we can fact check me on this, but my understanding is that the Omicron is more localized to the upper airways.
All right, so this is something that we will have to explore more deeply.
I can figure it out right now.
All right,
if you want to keep going.
It's a good question. So Dr. DeLay and I will usually come down on opposite sides of most questions that you ask us, and so this is an excellent opportunity.
That's not true.
Not most. Only the ones that are mysterious and not yet understood. But this is where we're going to start to get into the macrophage activation syndrome, and the reason that I think that Omicron would be hanging around in the body less is that it's less severe, and so macrophage activation syndrome is the reason for the extended disease and the severity that we see, that we wouldn't expect to see it from something like Omicron. However, it looks like
Omicron's localized to the upper respiratory.
But that we haven't connected to that versus... I gotta look into this as well. It does seem like Omicron is localized to the upper airways, but technically so should Delta.
I think Delta has a greater... I don't know how to find this comparison.
Let's look at this later. Come on, we have to move on to other questions. My point is moving on from the sort of the PCR question, which is an excellent question, and we will look into this. We have that the purported statement here is that the ongoing inflammatory response in patients with severe COVID is a consequence of the hyperactivated immune system rather than of inadequate viral clearance. And we have activation of macrophages. They produce cytokines that go far beyond the point of the clearance of the virus. And this is what Dr. DeLay was saying, which is that this might be related to the failure of natural killer and cytotoxic T cells to get rid of the activated macrophage. Because if you don't have them around to take care of it, then you can't do anything about it. And there's a decent amount of work that's been done on the fact that there aren't as many T cells around when you have severe virus as there should be. And so the details of why that is the case are still kind of misunderstood, because it's apparent that you have some kind of T cell exhaustion, because when you start to count cells in the fluidic systems of the body, you don't find as many activated T cells as you should. And so the question is, where are they? Have they gone expressively through the body? Is it that they've died because they've encountered something that's damaged them and they can no longer survive? And it's not totally clear of why they're not around to take care of this. But do you want to hit on macrophage activation syndrome?
Yeah, let's do it. We have some slides on that.
All right. All right.
So this is the paper that this figure is coming from. And so at the beginning of the pandemic, this was referred to, this idea of a cytokine storm was seen in a number of the severe patients. And so I think it's important to understand what the cytokine cascade is supposed to look like in a healthy patient. So over on the left-hand side of this figure, we can see that when you have a typical viral infection, you have this cooperation between these activated macrophages and the antigen-presenting cells that essentially results in destruction of infected cells and leads to eventually the macrophages are doing their jobs and then they're killed off. And so the main problem that's happening here, if you look over in the center figure, is that these cytotoxic lymphocytes, those are like T cells that we're talking about, and macrophages aren't killed off. There's a problem in the feedback there between that compartment, those T cells and the macrophages, and you don't see the proper signaling with the cytokines that you would expect. And over here, in the COVID case, you can see the similarities to the macrophage activation syndrome, which is normally found in these autoimmune disorders. Let's see here. In this case, the problem comes down to a problem with this interferon signaling feedback loop and exhaustion of the T cells, so they're not actually able to do their regulatory job. You also have this complement activation cascade, which plays into the clotting procedure that we talked about before. But it seems that the complement activation also leads to this persistent interferon signaling, which continues to promote inflammation and further exhausts the T cells that should be hampering the macrophage activation. So
do you want to do complement now too?
Yeah, so we should probably look at what the complement system is, but what's important here is that macrophage activation syndrome is a fairly well described immune disorder that happens in autoimmune disorders. And it bears a very striking similarity to the cytokine storm that you've heard popularized about COVID mechanistically. And this is a very good case of the body kind of working against itself because you have dysregulation of this interferon signaling pathway, which could be in part due to the virus trying to evade the immune system. But it sort of also points to an inherent dysregulatory capacity of the person's immune system in the first place. Let's see, and then of course we have this complement activation that plays into it, and I think it's worth looking at the complement pathway in general because we've talked about the complements a lot, and I don't think that we've seen. Again, we're gonna I think hopefully. So again, short little video about this, but the salient point is that you have these inactivated monomers that are sort of present in the blood at all times. And when these cytokines begin to signal, they are changing the shape of these precursor complements, which are then rafting together or activating one another. And they're going to result in not only further amplification of the immune response, but they're going to also produce some pretty cool structures themselves. So, do we share a sound too?
Mm-hmm,
Okay,
it is.
cool. Then you need to. So we could just bring a different plug for that.
Sorry.
All right, so let's watch this maybe on 1.25 or something.
Every living being needs to fight off other living beings that want to feast on them. So as multi-cellular life evolved over billions of years, it came up with ways to defend. Every living being needs to fight off other living beings that want to feast on them. So as multi-cellular life evolved over billions of years, it came up with ways to defend itself. Today, humans have a sophisticated defense network, like physical barriers, defense cells, and weapons factories. But one of the most important defenses of our body is largely unknown: the complement system. It evolved over 700 million years ago and is an army of over 30 different proteins that work together in a complex and elegant dance to stop intruders. All in all, about 15 quintillion of them are saturating every fluid in your body right now. Guided by nothing but chemistry, these proteins are one of the most effective weapons we have against invaders. Many other parts of the immune system are just tools to activate the complement system. But it's also really dangerous. Imagine having trillions of little bombs inside your blood that could go off at any moment. So our cells use numerous mechanisms to prevent complement from accidentally attacking them. Okay, what exactly does it do, and what makes it so dangerous? In a nutshell, the complement system does three things. It cripples enemies, it activates the immune system, and it rips holes in things until they die. But how? After all, these are mindless proteins randomly drifting around without will or direction. Well, this is actually part of the...
Yeah. It also leads to clotting too. So this is... We'll talk about that in a minute. But he left that up. I'm sorry.
Every living being needs to fight off other living beings, spread very quickly. Imagine the complement proteins as being like millions of matches very close together. Once one catches fire, it ignites the ones around it. They ignite more, and suddenly you have a big fire. To show the actual mechanisms of the complement system is a tad complicated and overwhelming, so we'll simplify here. Now, let's imagine you cut yourself and a bunch of bacteria enter the wound and make it into the surrounding tissue. Our complement attack begins with C3. C3 is the first match, the initial spark that will start our fire. And to do that, C3 needs to switch from passive to active. How this happens is complex, but let's just say it can happen randomly through other complement proteins that bind to enemies or through antibodies. All you really need to know is that C3 breaks into two smaller proteins, C3a and C3b, that are now activated. One of these parts, the C3b protein, is like a seeker missile specialized in bacteria, fungi, and viruses. It has a fraction of a second to find a victim, or it will be neutralized by water molecules. If C3b does find a target, it anchors itself very tightly to its surface and doesn't let go. By doing so, the protein changes its shape again. In its new shape, it's now able to grab other proteins and start a small cascade, changing its shape multiple times, adding other complement proteins to itself. Finally, it transforms itself into a recruiting platform known as C3 Convertis. This platform is an expert at activating more C3 proteins that start the whole cycle anew. An amplification loop begins. Soon, thousands of proteins cover the bacteria. For the bacteria, this is very bad. It can cripple the bacteria and make them helpless or slow them down. Imagine being covered by thousands of flies. But there's more. Do you remember the other part of C3, the C3a protein? C3a is like a distress beacon. Thousands of them flood away from the site of battle, screaming for attention. Passive immune cells notice the C3a proteins and awaken from their slumber to follow the protein tracks to the site of infection. The more alarm proteins they encounter, the more aggressive they get. This way, complement guides reinforcements exactly to the place where they're needed the most. So far, the complement has slowed down the invaders and called for help. Now, it's beginning to actively help to kill the enemy. The first immune cells to arrive at the battlefield are phagocytes, which means cells that swallow you whole, trap you in a tiny prison, and then kill you with acid. But to swallow an enemy, they need to grab it first, which is not easy because bacteria prefer not to be grabbed and are sort of slippery. But now the complement that has anchored itself to the bacteria acts as a sort of glue that makes it easy for the immune cells to catch their victims. But it gets even better. Imagine being covered in flies again. Now, imagine them turning into wasps. Another cascade is about to begin. On the surface of the bacteria, the C3 recruitment platform changes its shape again and begins to recruit new proteins. Together, they begin the construction of a bigger structure, a membrane attack complex. Piece by piece, new proteins, shaped like long spears, anchor themselves deep into the bacteria's membranes, until they rip a hole into them that can't be closed again. Fluids rush into the bacteria and their insides spill out. They bleed to death. The remaining bacteria are maimed and...
All right, so I think that is as far as I wanted to go. So there's a similar... We were talking about the inflammasome. This is a very similar structure, except instead of attacking cells, in this case, this is actually attacking the viral particles or the bacteria or whatever the invader is itself. And generally, when we think about the complement cascade in terms of immunology, we're talking about the elimination of the pathogens. But one of the other aspects of it, which I think we have a slide here for it, is that the complement system also activates the pieces of the of the clotting cascade. In particular, it activates platelets, which you can see here. So these are all the different complement molecules over here. That they have names like C3 and C5 and so on and so forth. And they're actually leading to the downstream activation of these platelets, which can then go on to raft together and form clots. And this makes some sense because generally, if you have a wound in your skin and you have some pathogen showing up, you probably want to seal off the access to that area. You need to put a roadblock up. This becomes problematic in the lungs, obviously, because you don't want to have blood clots in your lungs. You can't breathe.
But so this leads us really nicely to, I think, figure 3 of the paper, actually. So if we can switch over to...
Yes, ground glass syndrome.
There's a bug that you have to hit the mute when you full screen it for some reason.
I should just stick a jack in the side here.
Anyways, so when you have the development of COVID inside of the lungs, you end up getting what is called these ground glass infiltrates. And this has to do with the complement cascade and the clotting and
macrophages,
the accumulation of macrophages and fibrinogens, and basically the hardening of all of the material that is inside of the lungs that should be warm and wet and thin and gas permeable, and basically just snarling into this mess of inflammatory markers, immune cells, and clotting cascades. And so if we were to look at the previous page here, at the very, very bottom, they talk about, I think that this is, somebody asked, I think Ava asked about this, about the an increased serum ferritin is typically associated with macrophage activation. And finally, the clinical features and multi-system organ involvement of severe COVID-19 closely overlaps with macrophage activation system or syndrome / hemophagic lymphohistocytosis syndrome. So what this basically is just a mess of clotting cascades mixed with macrophages. And so your macrophages are in this highly inflammatory state. They have been mixed together with platelets that are causing things to come together and to stick together. And then all of this is basically lining all of the surfaces of the lungs. And conspicuous hemophagocytosis and secondary hemophagocytic lymphohistocytosis-like syndromes are present in most cases, which is just the fact that because the complement is activated, it's not going to target, this membrane attack complex isn't going to target its own cells. This is solely made for targeting pathogenic cells that have gotten into the body.
And that's the main difference between it and the inflammasome.
Exactly. So the inflammasome targets the cells of the body, and so when you activate the inflammasome is going to eventually lead to the death of something like the macrophage. When you activate the clotting cascade, all of this is happening on the outside of the cells. So you're basically just accumulating garbage that you can't clear because all of the pathways to get there have been blocked.
It's also worth pointing out that some of these complement players are actually toxic in high levels by themselves and actually kill off some of the endothelial cells. And this is behind the endothelialitis that was mentioned before class. Mm-hmm. So I'm just looking here. Complement C5 is an anaphytoxin, and the membrane attack complex can also be toxic to those cells too, just by having it around. So I guess it can actually somehow disrupt the membrane of the host cells inadvertently. I don't think that's what it's designed to do. It's just, I think, in high quantities.
I think that it might just be something that aggregates. Like you basically have a tremendous amount of garbage that's being secreted into the space between cells. And actually, what they mentioned just before they start talking about these ground glass infiltrates is the fact that when you have all of these dysfunctional cells, lack of T cells, lack of killer cells, in addition, you have chunks of complement circulating in the outside of the cells. You're creating an environment where the immune system cannot effectively surveil things, but there's lots of food around. And so you can get secondary infections because normally what happens when you breathe something in is that you have cilia that basically like neatly move the mucus out and everything is kind of kept clear. But when you begin to accumulate dysfunctional pieces of immune system there, the cilia are no longer able to work, and they're allowing things to get deeper and deeper into the lungs. And by the time that they penetrate to these deep areas, you can just have rampant bacterial overgrowth because the bacteria actually can move around in these environments because they're capable of producing various alginates and various sugars that allow them to glide through these spaces. And so it's a perfect colonization environment for bacteria. Is there more on the complement topic?
I don't think so. Again, the healthy endothelium is perfectly capable of defending itself against complement, which is existing in perpetuity in background levels. There's soluble factors produced by the endothelium in healthy tissue that are capable of neutralizing some of those toxins. There's membrane-bound factors. There's all sorts of ways in which healthy endothelium can protect itself. And this is almost certainly another case, although it's not printed here, of there being a pre-existing dysregulation of that endothelial tissue that sort of amplifies this process. And so something that may have been a little problem starts to pile up. And then now that it's becoming a bigger problem in the endothelium, you have a greater inflammatory immune response to it, and you just get these feedback loops where, this is a concept that if you get nothing else out of this, is that the body is unfortunately susceptible to catastrophic feedback loops, because at every chance you have the opportunity to either amplify a response, which means go and get more help, or to call off the entire war. And you have almost an infinite series of decisions of where to go with that, and they can go sideways at any one of these points. And so I think that this endothelialitis is just another example of a tissue sort of responding in a way that might be suboptimal, which is then perhaps, if you already have some immune dysregulation, then you're going to see it piling up and feedbacking, and you get yourself into a real pickle that way.
I think that we should take a stretch break, and then we should do the last half or the last part of this paper. What do you think?
Yeah, sure.
Okay. So for the last, we've kind of talked a lot about the way that coronavirus is causing problems in the lungs. We've talked about these infiltrates of the platelets and everything else of the complement. I wanted to get a chance to talk about this last figure, which is kind of this overview of how this is all happening. I very much prefer to look at figures than I do to look at text, which I think is kind of probably the case for a lot of people. I'm very much a visual person, and so I like having this figure, and I want to make sure we get to it. But before we do that, I want to go through the platelet activation and increased circulating serotonin, where I think that it was, I think Andy asked about this. Dr. Delay really doesn't like when I mention people's names because we're going to post it to YouTube and we don't want to disanonymize you. So
more editing work later.
Yeah, it's more editing work later. I'm sorry. Okay, so basically
So how does this work?
There's a crazy statement in here, which I actually didn't know before I read this paper, which was the fact that among mediators released from the granules of activated platelets in COVID-19, serotonin is unique in that 95% of the total body serotonin pool is stored within platelet granules. That's wild. Okay, so the fact that a healthy pulmonary endothelium is required for the clearance of the released serotonin, that doesn't really surprise me because we know that a healthy body is necessary for the clearance of any of this stuff. The same way with the virus, the same way with the neutrophils, the macrophages, whatever. But the fact that serotonin is largely sequestered in the platelets isn't something that I had come across before, but now it's relatively easy to kind of slot it into what I already know about the body, which is the fact that the things that we think are one function,
Systems.
Hmm?
The idea of systems, right? You have like the nervous system and the circulatory system. Like the disintegration of them is kind of a myth.
The disintegration of them is kind of a myth, but I was even thinking about more like when I was doing my PhD, I was studying antibiotics. And antibiotics are always referred to as this thing, which is this molecule that we use to kill bacteria because it's necessary for human health. And then as I was studying antibiotics, I came to realize that, well, actually, these are compounds that the bacteria are releasing, and they're using them as they're using them to communicate. They might actually even induce the growth of antibiotics. And so if you have a sufficiently low concentration, the cells use them as boosters to be able to grow much faster and much more densely. And this is, now I'm seeing it recapitulated inside of the body, where you see something that is normally presented to you as being a substance with one function. And that function has to do with your spiritual and emotional well-being. But in reality, it is a substance that is, in the vast majority of cases, solely used in the clotting cascade by platelets that need it to be used during clotting in order to vasoconstrict the area that is being worked on.
That's to squeeze the blood vessels.
Mm-hmm.
And this makes sense too, because like if you've ever had like a minor surgery or anything like that, if you've ever had something like some scalpel cut on your skin.
Do they hop you up with happy drugs? They just rub some serotonin on it?
Well, they don't use serotonin, but they do inject you with a vasoconstrictor. And so you don't really bleed much. It's kind of amazing. And so that
marvels of modern medicine.
Yeah, it makes a lot of sense that serotonin could be used for that. And there's this redundancy, which is what I was saying, like the sort of overlap of organ systems in the body is kind of amazing. It may also make sense that you want to store something as reactive as serotonin inside of an actor that is not likely to be inadvertently activated. If that makes sense. So you would want to lock up the firearms. I just can't help myself with the analogies. You don't want to have these very reactive molecules. Obviously, if you have platelet activation, you either have a cut or you're about to die because there's a blood clot that's going to go in your lungs or in your brain or something. So there's a very restricted set of circumstances that you're going to have clotting, and obviously this clotting associated with COVID is a fringe case scenario that is not supposed to be happening necessarily.
And so what's interesting in this fringe case is the fact that there appears to be some kind of fundamental change that is happening to the platelets in COVID patients. And I have to, whenever I talk about COVID in general and the things that we point to and the things that seem weird, it's really always super important to remember that there are almost no diseases that have so captured the imagination of so many so quickly with so much money directed to them. The only other version of this that I think is possible is cancer, maybe, where cancer is such a broad class of diseases. And that's kind of
but yeah, you're right.
That's kind of what I mean, which is the fact that when you start to look at COVID-19, you basically start to see that there's all of these different ways in which things can be dysfunctional. And the more that you find out, the more that you find that there's these permanent changes that happen to cells, and the cells begin to behave in some strange way. And so in that sense, to me, on a philosophical level, there is similarity between the dysfunction that you see in something like COVID and the dysfunction that you see in something like cancer, if only because the complexity of it continuously appears to enlarge the closer that you look at it. There's a philosophy in science that suggests that looking at molecular pathway interactions.
They're also both, sorry to interrupt you, they're both fundamentally engage the immune system as part of the pathology. Because, you have neoplastic cells that appear every day throughout your body. But you have all these different immune checkpoints that are able to quickly eliminate the threat all day long. It's not a problem. It's not a problem. And it's not a problem. And then one day, your immune system is busy doing something else, and something slips through the cracks. And this is how you get the development of serious cancer.
I don't remember what I was saying. But to go back to the sort of the factor inside of the paper, we have that there's a change that happens inside of the platelets that is carried through, where they noticed that if you take the platelets from patients with COVID-19 and you give them to a different patient, that they are actually able to transmit whatever they're doing to healthy volunteers. So in addition, platelets from severe COVID-19 patients have been demonstrated to induce tissue factor expression ex vivo in monocytes from healthy volunteers. And so basically what they're doing is they're taking these platelets, they're putting them with monocytes, and even outside of the context of a highly inflamed body, these platelets are basically able to inform the cells that it's like, hey, we're going full stop on a clotting cascade adventure, and you're going to help me. And so that indicates that there's some kind of longer term change that is part of the etiology of the damage of the system, because the cells have been actually reprogrammed where even when you put them into a healthy environment, they are no longer able to bring themselves back to this baseline of, oh, well, there's actually no reason for us to clot here. Like, we can stop this.
It's a runaway train.
It's a runaway train. The presence of serotonin looks like it's activating this sort of this thrombogenic fibrosis that's developing in the lungs of COVID-19 patients, because we saw earlier that these activated macrophages are interacting with the platelets. And so you have the complex of immune cells that are dragging platelets to them. And as the immune cells die, the platelets are still attached to them. If they haven't already released their massive quantities of serotonin, then they do release their massive quantities of serotonin. The vasoconstriction at this point then prevents other immune cells from being able to come in and take care of what needs to be removed. So if you're thinking about surveillance in the body, you have cells that die. Like, for example, if you have an ingrown hair and you pop the sort of the cyst that the ingrown hair is in, a bunch of white stuff comes out of it. That white stuff is almost certainly not bacteria. That white stuff is dead neutrophils. And neutrophils are these cells that are filled, they're granulocytes. They're filled with molecules that are meant to destroy diseased or affected tissue. And
not just neutrophils, but also their extracellular junk. Like, they make these nets. They call them nets.
We have a slide on this.
Yeah.
That's a good point.
Go ahead.
But so you have all of these cells that basically accumulate that it's not a bacterial infection. It's just goo of dead cells. They're not necessarily rotting. It's a perfectly sterile environment, but you do have to clear that at some point. But if you're releasing all of the serotonin because of the way that these platelets are interacting with their environment through this hyperactivated state, you're basically closing off entire compartments of the body and preventing surveillance from coming in that is able to clear stuff out. Like, you have to have movement.
But normally that could be quite useful to have these sort of things appear, right? You got to remember that the immune effector cells need to walk. They're actually the only cells in the body that walk around and do stuff. And without some sort of scaffold to walk around on, they can't do their job. And I speculate that is largely the job of these extracellular matrices that are being deposited, is to make a sort of, workspace for the immune system to do its job.
I would agree with that. I think let's look at this last overview picture. I mean, we're gonna see a lot more of the pathology of COVID. Next week's papers are a little bit more readable, I think, than this one. One of them is basically like a perspectives, which is meant for a more general audience. And then we have a paper about beta amyloid plaques being formed in the brain, which may or may not be. We'll talk about, like, correlation does not imply causation after we finish reading that paper.
Yeah, this is all, it's worth mentioning, we'll probably said it before, say it again, we're still understanding how all of this works. These are, and science in general is always this art of integrating new information, sort of whittling down all the different possibilities of what could be happening, and slowly beginning to focus on something. And so we're much closer this year than we were last year at understanding what's happening. And this figure here does a great job of outlining the sort of state of the science as it is today. But if you'd looked last year, you'd see a figure like this that was even more complex and complicated, because there was other players that they weren't sure if they were the main actors and so on and so forth. So what's going on here?
I mean, basically on the left side of the figure, you have what it looks like just before things start to go awry. You have the bronchial epithelium is still a stable epithelium. The basement membrane is intact. The alveolar epithelial cells are still totally normal. They're perfectly functional. They're doing their jobs, both type 1 and type 2. There are alveolar macrophages that are around that are basically surveilling the area to see what's happening. And you can see that they have a couple of things on them. They have these PAMPs, which are... they're
another pattern recognition molecule.
It's like pathogenic associated molecular protein receptor. Technically, it should be PAMP-R. And this is a pattern recognition receptor. And so these are basically going around and they're looking to see, like, can I find something that looks like it shouldn't be there? And you also have these alveolar cells, type 2 cells, which are able to, in the case of infection, start to release all of these cytokines. And these are the ones that actually have ACE2 on them, right? So there's not as much ACE1 on these type 1 cells. And so when SARS-CoV-2 comes into the lungs, it interacts with these type 2 cells, it interacts with these alveolar macrophages. You start to see the expression of all of these cytokines and these chemokines, and then those cytokines and chemokines are the ones that are calling all of the immune cells to come through. We actually found an error here which says that there's monocytes here that then turn into T cells, but this should be peripheral blood mononuclear cells, which are...
It's just a general term for any sort of white blood cell, basically.
But monocytes are a specific cell type that excludes the T cells, and so it's a little bit
confusing. But yeah, that's not actually the same cell.
But you have the cytokines that are produced here, especially IL-6. IL-6 is the cytokine that breaks open the barrier, the tight junctions between these endothelial cells to allow the passage of monocytes and neutrophils into the lungs. And it calls to them because they want to move towards it. They want to move up this concentration gradient of IL-6. And once they get here, the T cell is interacting with the macrophage and it's turning it into an inflammatory macrophage. And this is when you start to get this macrophage activation syndrome, because you don't have the T cells that are necessary to turn it off. You just have the T cells that are necessary to activate the entire thing. And once you have severe dysfunction in the lung, you're releasing all of these other compounds from these neutrophils. And neutrophils are basically like bombers. They kill stuff, the things that they contain within them. Histones are inflammatory. MMPs, reactive oxygen species, all of these things are basically little bombs that they drop on the cells in order to make it harder for bacteria to survive. And as a corollary, they also kill your own cells. And so you start to get severe dysfunction on the right of the alveolar epithelial cells, and which is labeled here as complement-mediated endothelialitis. So the complement system, which we were talking about before, is non-discriminately killing the cells that are on the surface of the alveoli.
Actually, they're actually down below it. So these are epithelial cells. So right down the layer, right below it, are the endothelial cells, which is a little confusing.
You're right.
But the same effect is in place. And again, a runaway feedback loop is playing out. Which makes this, it's actually a little sad and hard to talk about, because you're really just talking about all of these processes that are supposed to be working as they are on the left, that are just sort of out of control, runaway train, and leading to, more damage than perhaps the virus by itself would cause, which is tragic, but it seems to be the case.
And so this is why one of the best things that can be done as a preventative measure to all of this, I think, is taking good care of the immune system.
And what's that mean?
What that means is eating in a way that doesn't encourage inflammation, right? Things like, I think that this is something that people have to wander into themselves. And so I don't want to list off a bunch of things, but I do think that diet, exercise, sleeping well, not exposing yourself to an excess of blue light at night and like the wrong kind of light at the wrong time of day, getting enough sunlight, getting as many vitamins and minerals as you can, basically taking care of yourself, not being hyper stressed.
Having like good positive relationships. There's an enormous neurological component, which we're going to get into next week. There's a lot you can do to take care of your life, which is easier said than done. It's obviously, and it's literally impossible to live perfectly, obviously, and even if you dedicate your life to it.
Like our immune systems will get us all in the end.
True. Yeah, we're all headed for the grave eventually. But, you can do a lot of things to really make it literally just less stressful on your body. And that seems to be the key, really. A little, and I don't mean like not working out stressful, right? Because a little bit of stress here and there actually strengthens you.
Mm-hmm.
But when things get out of control, when you feel like you're falling behind on sleep, you haven't gone to the gym in a while, those kind of things are when you really start to get out of balance.
Mm-hmm. Yeah, and I think that it's very important to do what you can to ensure that you don't live afraid of the consequences of something. Like COVID is definitely a freaky situation. We're all figuring it out as we go, and it can be hard reading these papers to not allow it to kind of settle into your brain of like all of these things that can happen inside of you. But the reality of it is that there's more control over this inflammatory response downstream, and we're finding out more and more about it. And so on some level, it's almost a relief to know that what it is the inflammatory response rather than the virus, because we actually have a decent understanding of how to control inflammation in the body, both on the level of, before it happens and once it actually happens just with medicines. And
behaviors, yeah.
I mean, when you're really sick, like you can't really behave a lot, right? Like I'm talking about the fact that like if something bad does happen and you do catch COVID and you do get sick, there's medicines that are being deployed that specifically are effective because they handle inflammation.
But if you're not in a state of inflammation to begin with, you probably aren't going to end up in that severe COVID category.
You can have a mutation. There could be any number of things that predispose you to a severe
The same could be said
outcome.
of cancer too, but you shouldn't go and smoke like 20 packs of cigarettes.
This is
right?
true. This is true.
You might be a child born with leukemia, but you might, be a guy who hung out with radioactive waste his whole life too.
Yeah, so like there's like vaping is very popular. You don't necessarily have to raise your hands on this, but how common is vaping?
They're all the good kids. Like, no, we never see anyone
we don't do
vaping.
any of that stuff. But like this is one of those things that it's a risk factor, right? Like when I was in college, it was cigarettes. Now it's vaping, but it's like these are things that are going to cause severe inflammation in the lungs. You're putting stuff there that shouldn't be there.
Just not sleeping, right? Like not getting sunlight. These are pro-inflammatory. We all live in Oregon, so that's
exactly.
What can we
getting
do?
sunlight during the winter. All right, let's look at the last of the... We'll get off our soapbox, and then let's look at the last of the presentation. We've talked about complement and clotting. Oh, this is the goo.
That's the extracellular net, yeah. This is the neutrophil webs. But all of these things, these interactions, can we go back to the last figure really quick?
Mm-hmm.
All of that... sorry, it was in the paper actually, don't worry about it. But there's all these interactions where one cell's touching another cell, and they have to be standing on something for that to happen. It's very central to the entire immune process, is that why do things go to the lymph node to interact? Well, because it's a really nice stadium for the game to play out in. That's the fundamental idea. There has to be a structured these are physical interactions, right? There has to be a place for it to happen. You can't just be floating around in a solution and hope to bump into one another.
Despite the fact that when you look at a scientific diagram, it always looks like things are just floating around and they happen to bump into each other. The inside of the body, like the inside of the body is very dense.
And so that's why that's why your body is producing all. At least, that's a hypothesis, right? Seems to be a reasonable function why a healthy body would produce these sort of fibrous plaques. Obviously you're trying to seal a wound, makes sense as well. This is just a diagram of that process.
Basically, so these neutrophils are granulocytes, which means that they have these are little granules that they contain within them that they carry around and they can release when it is necessary. So as part of what they do when they die is they release their nuclear chromatin. So they're basically throwing their DNA out into the environment, and the DNA sticky goo, and it basically tangles with the granules that they have expelled. I think that's the right word. Expelled, that they've expelled. And so what you end up having is that you just basically have this like caustic layer of goo that lays on top of things. And this can happen by two pathways. This is basically showing that you have one pathway where they degranulate first and then they release the chromatin, and the other pathway is that they basically, the nuclear envelope melts, the chromatin is then decondensed, released into the cell where it binds to all of the granules, and then the plasma membrane ruptures. But the end product is the same. You basically have caustic goo that coats everything that is very bad news. It's hard to clean up. We have a slide on endotheliolitis.
Yeah, we kind of touched on it already. I want to make sure we have time to answer questions. This is just showing the layout because there was some confusion earlier. The epithelial cells are, of course, the hairy ones on top. And then down below that, actually, below this membrane, below this basement, move this over, is this endothelial layer. And this is sort of the interface with the vascular system, which is why it's such bad news if it gets infected, because now you're talking, or not even infected, if it gets disrupted, because you're talking about an inability to traffic both an inability to traffic cells to the right location, and also just a widespread dissemination of waste products, inflammatory cytokines, and things that are just going to end up in the wrong part of your body and cause alarm and havoc.
Did you want to look at this?
I don't think we'll have time today. Yeah, I think we should probably just wrap. And
what time are we at? 21?
Yeah, we have about a half hour left.
Almost. Hold on. We'll skip the flow cytometry. Flow cytometry is a method that they use to actually be able to look at these cells. We'll talk about it a different day. I wanted to talk about something that's in the second paper, which is this thing called antibody-dependent enhancement. And we've kind of talked a lot around this over the course of the last paper, where we've been talking about the activated macrophages and the complement cascade. But antibody-dependent enhancement is this weird thing that happens where antibodies actually make a situation much worse than they would otherwise, which is that you can have two types of IgG. You can have IgG that is non-neutralizing, and you can have neutralizing IgG. The difference between these two is the fact that neutralizing IgG is actually capable of neutralizing the threat, which means that it binds to the capsule of the virion or the spike proteins or whatever it binds to.
Some important part that it needs to work.
And it cannot continue working without it, or with IgG bound to it. And so basically you have effectively created a neutralized virus. And so when these Fc receptors that are on the surface of the cells pull on the ends of those antibodies and they pull them into the macrophage to be digested in the lysozyme, a neutralizing antibody is basically frozen the virions to such a degree that they can't replicate. In antibody-dependent enhancement, and this is for dengue virus, and this, I think it's a feline virus, FIPV. What happens is that they get into the lysozyme and they're not neutralized. They've been pulled in through this Fc receptor, but they're able to replicate inside of this lysozyme, and so you get macrophages that are traveling around. And then the same thing can happen with this complement cascade, where basically you form this immune complex inside the alveoli. You recruit immune cells, you recruit complement, you recruit pro-inflammatory secretion, but you're not actually stopping the virus from replicating. And what's happened is that the viruses are now so coated in antibody that they've created a safe space for themselves where they can't be neutralized. And so as all of these cells begin to become dysfunctional, And if they do end up capturing some of these viruses, you just have this collection of like very, very sick cells that are all grouped together in the same place near to virus that is happy to infect them if the opportunity arises. We talked about toll-like receptors already. This was, I mentioned this RIG1 because we talked about it a little bit in the second paper, but it's basically just another mechanism for being able to turn on these interferons. It's associated with mitochondrial surface proteins, and so it's slightly different than the toll-like receptors, but not significantly, in that the end point is that you're producing interferons. More interferon stuff. We'll keep these up so you can look at all of the photos, or all the pictures, but I don't necessarily think that there's much to learn from here.